Did you find the part on the primary and secondary hypertension?
Mm-hmm.
What's the answer?
It says that primary is that, doesn't it say that it's hereditary and environmental?
Okay, essential primary hypertension accounts for 90% of the cases in adult population. Let me see, the risk times in hypertension increases.
Unhealthy
Hereditary
lifestyles.
in combination with unhealthy lifestyles. Okay. And then
So is it kind of like modifiable and non-modifiable factors?
Yeah.
Like smoking, obesity.
So secondary would be the modifiable and primary non-modifiable?
Primary is
That-
like pyelonephritis.
Yeah.
Like a specific cause, like renal
Yeah.
deficiency.
Because
Oh, so the hypertension is caused by another diagnosis.
Mhm.
All right,
Okay.
okay, so primary
That
is
makes
caused
more
by the
Like
modifiable
lifestyle.
risk factors,
Okay.
diet and environment, lifestyle.
Yeah.
And then secondary
secondary-
is caused by another diagnosis.
Yeah.
Okay.
Renal failure or whatever.
The target organ.
Fabulous.
it says renal parenchymal disease.
Target organ damage?
Okay, so I'm gonna talk about the heart and the kidney and the meds and the stuff a little bit. And then we'll go from there. Okay. Here we go again.
Oh, it even has a picture swap. Look at that.
Well, you can just let me know if I missed something. Oh, yes, that one has a picture.
I'm about to draw it.
It's very important. And you don't have to draw a picture. Like I say, you can find a picture off the internet. It doesn't even have to be a human. It could be an animal. It's just something to attach your learning to. If you have a family member that has heart failure, that's the person that you're going to think about when you're studying heart failure so that you can attach it. If you think about the stuff you know really well, it's either happened to you, it's happened to someone you know, a family member, your pet, whatever. I've known people that are like giving their pets blood thinners and doing all kinds of stuff. So, you know, whatever it takes to remember that stuff, you know. Okay, so we've got the aorta, we've got Betty's kidney, big kidney. I'm not sure what I'm gonna need here, so. All right, so we have a patient with, well, let's just talk about the heart real quick. So the heart has two systems, right? It has an electrical system, so that's just like any kind of machine that you have. Let's say your car, it has a computer in it so that your car knows what to do, right? The car has to do the electrical stuff so the mechanical stuff will work, okay? So the electrical stuff has to work so the mechanical stuff can work. So we've got the whole electrical system EKG thing, okay. We also have the pump, which would be the atria and the ventricles, right? So what part of the heart does most of the work as far as perfusing the body?
Left ventricle.
The left ventricle, okay? It's gonna pump the blood out to Betty's body, okay? So that's something that's important to note, right? Right before the ventricles contract, we know the atria, they're kind of collecting blood too, and they say, oh, here you go, have some extra. And that's like a 30% cardiac output that they're giving us, somewhere around 30%, it's not exact. So we know that if the atria aren't working right, we're gonna lose, that's a lot of cardiac output. If you think about, we have 6 liters of blood in our body, 30% of that is a couple of liters. That's 2 liters now that you're not pumping around, where your body is expecting 6 liters, okay? So that's the kind of the normal stuff with the heart that's super important. And then of course we have our kidney that's very sensitive. Okay, we're gonna say it's like a little princess. Okay, little princess kidney.
I'm a kidney then.
Okay, and to make the kidney happy, it always has to be provided things, in this case, blood flow, right? So this is the blood flow. Okay, and we talked about the kidney and all the things that the kidney's responsible for, right? Let's refresh on that. What does the kidney do?
Filters.
Okay, so filter, hormones,
Erythropoietin, acid-base
okay, erythropoietin, acid base,
Vitamin D.
vitamin D, hormones, blood pressure, fluid balance. Okay, so though the kidney is, a little prima donna with the crown, whatever, they kind of deserve it, right? So they're responsible for a lot of stuff. So knowing that, when you're trying to figure out what happens when the kidney fails, then you just look at, well, none of this is going to work. And you kind of figure out what other systems are going to be affected. Okay? So when we have a patient who's in heart failure, someone whose heart is not working well, their heart is going to try to compensate by getting bigger. So the heart is like, oh, well, if I bulk up, right, I'm going to be able to pump better. But instead of bulking up and being muscular, the heart bulks up like on carbs. Instead of weightlifting, yeah, I know, they're on a carb binge, right? So their heart gets huge and floppy and ridiculous and not able to do what it needs to do. So we call that cardiomegaly, right? So most of our cardiac patients have cardiomegaly because their heart has been trying to compensate for a difficulty in perfusion for whatever reason, okay? And then it works even more poorly, okay? We know that the heart requires oxygen. It's a muscle, and you have to feed the muscle oxygen. So when we say feed the heart, we're talking about oxygen and nutrients, okay? So the heart itself needs oxygen, and then it's also going to deliver oxygen to Betty's kidney and all of Betty's organs, right? Okay, so that's kind of just a little quickie overview thing. Okay, what is the number one magical pill or medication that we're going to give our cardiac patient? What was number one on that list?
Beta blocker.
Beta blocker. Beta blocker. Okay. How do we know it's a beta blocker?
LOL.
Okay. What does a beta blocker do that is so darn magical, other than block beta cells?
It lowers blood pressure.
How does it lower? Okay, it lowers the blood pressure by vasodilating. Okay, and so that results in a decrease in blood pressure. What else does the beta blocker do?
Decrease the workload.
Decreases heart. Okay, yes, decreases heart rate.
Does it decrease preload? Is that all that?
Let's not get into the preload afterload thing right now. We'll get there in a minute.
Decreasing overall workload in the heart.
It does, but that's kind of what all of it does.
Yeah.
Contraction.
There was one extra credit question when I was in nursing school. When I think back, I think it was first semester, but now that I'm a teacher, I'm thinking it couldn't have been first semester, but it might have been, I don't know. And it said, what is Starling's law? And I got it wrong, and that's why I still remember the darn thing, right? So if you take, and I have lots of analogies, but because this class is all female and everybody has long hair, okay, you take a scrunchie, right? And when it's brand new out of the package, you're like, oh, it's gonna hold my hair nice and tight, right? If I shoot this at Marissa, boom, it's gonna hit her, right? Okay? I'm assuming I'm a good shot, right? But then you take one out of the drawer because now you can't find the new ones. I don't know where they go. They're with the socks and the whatever that are missing, right? And it's like stretched out, and you're gonna have to like turn it over like 5 times just to hold anything in your hair.
Like this.
Like that. Nice. Yes. Okay.
I couldn't find anywhere.
So if you have something that is like the more I stretch this, the farther I can shoot it, right? That's how the heart is. If I can stretch, that muscle, I'm going to get better recoil, right? The heart's going to go, shoo. And the heart doesn't have to do any work to do that. Okay? So we're going to stretch it passively, so the heart doesn't have to use any additional oxygen or effort. It's also like those really cool moving walkways at the airport or in Vegas, and you're walking and you're like, oh, I feel so good, I can walk so good, because you're doing half the work, right? It's kind of like that, okay? So the beta blocker is going to increase the stretch of the heart, and it does that by slowing down the heart rate, okay? So you've got your heart and it's beating, and you're at like in the 80s heart rate, and your heart's like, oh my God, I'm struggling, I've been getting bigger, and I'm so floppy, and I'm having so much trouble. Betty is so much work. I'm having to pump all of this blood out there. And so then this beta blocker comes, and it goes, ooh, I can slow down. And the slower I go, the more stretch I get. And what happens during diastole? What happens when I'm filling? You're stretching, but what are you doing to the heart muscle itself, other than just stretching?
Getting more.
You're feeding it, right? During diastole,
Oh, that's when the muscle gets.
when your heart is at rest, you feed the coronary arteries.
Yeah.
That's when the blood goes into the coronary arteries. That's why it's so magical, okay? So not only is the heart going, oh, okay, you're now on the moving walkway, and you got, 3 huge bags, and now you're like, oh, I don't have to do as much work, right? And then somebody comes along and hands you a drink, and you're like, ooh, I don't even have to go get the drink. Look how happy I am, right? It's the same thing. You're gonna slow down the heart. It's gonna fill. You're gonna feed the coronary arteries, so now the heart goes, oxygen. I have more oxygen, and I can do more work with more oxygen. And look, I don't even have to work to stretch. It's like almost automatic, okay? And if that weren't good enough, it lowers the pressure here. So the pressure that it's pumping against, which is the aorta, which is the body, decreases. So now, instead of I'm trying to pump the blood out of the heart through this really vasoconstricted high pressure, it's easier to pump the blood out too. Okay, so that's why a beta blocker is so important for our patients. So every cardiac patient that you have, we need to at least address the beta blocker. Okay? The people that are asthmatic or have lung issues won't be able to take the beta blocker perhaps, but otherwise it needs to at least be addressed. And if the patient can't take it for whatever reason, the physician has to actually document in the progress notes why they didn't order the beta blocker. And that's one of those national initiatives that core measures based on evidence that if a heart patient has a beta blocker, we have better outcomes. Patient does better. If it's easier to get the blood out of the heart, it's going to be easier to perfuse the body. We're going to make little kidney happy down here because the blood will get down there more readily. Okay? We do have potential heart rate issues, but some of these patients do better when their heart rate is in the 50s. Because remember, you're dealing with a fragile, damaged heart, and it can't handle those high rates. And that's why we always give the beta blocker before a procedure, even if they're NPO. We give the beta blocker when the blood pressure seems too low for us, but the doctor's written parameters that they want the systolic at 88. Because that systolic pressure is this pressure. So if this pressure is 140, this heart is going, oh my God, I can't push the blood out, and it's going to all back up, and now the patient is in fluid overload. Okay? So a beta blocker is super important. Do I need to check the blood pressure before I give it and the heart rate? Yes. And unless there's parameters, heart rate of 60, systolic of 100. If it's lower than any of those, then we don't give it. We call for parameters. Okay? So that's the beta blocker. So Betty's on her beta blocker now. It ends in LOL. And maybe she's still having problems. She's still not perfusing well. So the first thing the doctor's going to do is increase the dose of the beta blocker. Okay? And if that doesn't work, they're never going to be on two different types of beta blockers. If your patient is on metoprolol and carvedilol, you question that. That is not correct. Okay, so if that were on an exam, you would say, wait, they can't be on two beta blockers. They'll just increase the dose of one, or they'll replace it. They'll say, okay, well, let's DC the metoprolol and put them on just the carvedilol. Okay? So they should only be on one beta blocker at a time. But let's say that her blood pressure is still high. We're like, Betty, her blood pressure is still, systolic still 130, 140. Her heart rate's now in the low 60s. You know, that part's doing good. Her heart's getting more oxygen, but she can't get that blood out of the heart with that high blood pressure, okay? It's more than just the systolic, but that's the best for visual, because we all know the systolic really well, right? This is also called the afterload. Okay, think about a garden hose. Has everybody used a garden hose?
Mm-hmm. Yes.
And you turn it on, and you turn it on a little, and you're like, it's like dripping, and you're like, come on. You turn it up more, because you want more flow, right, more pressure. And so there you are, you're trying to water your plants, and there's the water. And it's just, and you're like, really, I can't get to anything, right? So what do? You make the diameter smaller by putting your finger over it or your thumb, and now you're like, right? And you feel all powerful, and you can spray the yard and everything. So, you know, the pressure, when you have a smaller vessel, when you're vasoconstricted, the pressure is higher, just like the garden hose. When the smaller the diameter, the higher the pressure. Or you can think about a boba straw versus a coffee stir stick. And that's what I bring to class when I teach this. If you think about a boba straw is the vasodilated vessel, and the coffee stir straw is the vasoconstricted vessel, the high pressure, high blood pressure. Boba straw is the low blood pressure. You can think boba, low, you know, whatever works for you. And so if you're trying to drink your milkshake through the boba straw versus the coffee straw, you're not going to get anywhere with the coffee straw except out of breath and upset because you can't get your shake, right? Or the boba. They're just going to stick to the end, right? And that's what's going to happen to the heart. If that pressure is so high, this vessel is so small and so constricted, the pressure is so high, the heart is just going to get fatigued. But if now someone comes to your rescue and takes the coffee stir stick out of your shake and puts a boba straw, and man, you're just drinking that like crazy, and now you're happy and all sugared up and, you know, whatever, well, that's what's going to happen to the heart. The blood's just going to flow out much more easily. Okay? So the next thing that we're going to add, if we have difficulty with the blood pressure, would be the ACE inhibitor. Okay? So the beta blocker is for the heart. So when you think about a beta blocker, you need to think about it's for the heart. I know it's doing other things, but we need to pull you out of just saying, oh, that's for the blood pressure, that's for the heart rate. Okay? The beta blocker is decreasing the workload of the heart. It's giving itself oxygen, it's doing a passive stretch, and it's more easily pumping the blood out of the heart because it's vasodilating and lower the pressure. You need to say that to yourself about 1,000 times so that when you get it and it clicks, so many other things will make sense. Okay? Okay, so the ACE inhibitor, we've already got something for the heart, and it's not doing everything we need. So now we're going to tell the kidney, look, knock it off with this angiotensin renin business, okay? We're fine. You don't need to be involved. This does not concern you. We want the blood pressure low, so stop trying to make it high. It blocks that whole thing. So if you think about it's trying to increase the blood pressure, and the ACE inhibitor is going, stop doing that. Okay, whatever. I'm just making this up as I go. So that's the ACE inhibitor. Okay, now what? And we start with that one because it's cheaper. There's no other good reason for that. So what do they get that tells us they don't tolerate the ACE? What side effect? Adverse effect.
Angioedema?
Angioedema, dry cough.
What do ACE inhibitors end in?
Pril. Play right
Pril.
in Las Vegas.
Thank you for asking that question.
Play right in Las Vegas.
So if it ends in Pril, it's an ACE inhibitor. Good. So they get a dry cough, and the doc says, okay, well, you're not tolerating that, so we're going to switch you to an ARB. And it does the same thing, it just does it like down here. Okay? Instead of the conversion process, it's in the receptor process. And the patient does better. How do I know it's an ARB?
Oh, Sartan. The tag?
Yeah, sartan, artin, whatever. Are they going to be on an ACE and an ARB?
No.
No, they both affect the kidney. You only need one. If it's not working well, what are they going to do?
Change it.
Well, they're going to increase the dose first. Okay, and then if it doesn't work, they might change it or add something else. Okay. What are some other things we can do to help this poor heart pump blood better to Betty? We've got our beta blocker it's doing all those magical things, right? What else is going to help the heart?
Thin the blood?
Thin the blood. Where am I going to put that? I'm like looking at the video. Blood thinner. So every heart patient should be on a blood thinner. It doesn't matter if it's aspirin, a baby aspirin, versus some brand new Xarelto or whatever, but they need to be on something. Okay? Why does a blood thinner help the heart?
It's not as thick, it's easier to push.
Yeah, it's not as thick, so it's easier to pump water than it is to pump syrup. Okay? All right, so blood thinner for sure. What else?
Diuretic.
Diuretic, especially if we are now having the blood back up because we aren't pumping the blood out very readily, right? And then, what's the most common diuretic that we give our heart failure patients?
Furosemide.
Lasix, furosemide. And so if they're on furosemide, what do they need?
Potassium.
They need potassium. Okay, it's not, because what'll happen is a lot of our patients are usually elderly, and they may have really high copays, or no insurance, or poor insurance, and so they may have to decide, I can only afford this one or that one. This is the one you want to afford first, right? And you don't want to have one of these without the other, because, cardiac arrest, low potassium, high potassium. Okay, so teaching is really important with these things. Okay. So we've got the beta blocker, we've got the blood thinner, we've got the diuretic. So, if there's less volume for the heart to have to pump, it's going to be a little bit better, okay? Otherwise, it's going to drown. We call that the preload. So for very simple terms, the preload is the pressure inside the heart. And the pressure usually comes from fluid volume, okay? And then the afterload is the pressure it has to pump against outside of the heart. after the heart, right? Before the heart, after the heart, whatever works. Okay, so we've got the ACE and the ARBs. If we still have a high blood pressure, what are we going to add? What can we add? What if the patient is now an AFib and antidysrhythmic, right? Calcium channel blocker or an antidysrhythmic like amiodarone. So
Cardizem.
yeah, cardizem, diltiazem. So the calcium channel blocker, which will slow this part down, the SA to AV. So the heart is doing its thing, and it's trying really hard to stay in a good pattern and have a good stretch. And the people that are the bosses, which are the SA and the AV node, are like, come on, hurry up, let's go. And then you give them a calcium channel blocker, and they're like, oh, that's all right. We're okay in the 50s. Just, keep chilling. Or the antidysrhythmic. If it's AFib with rapid ventricular response, AFib with RVR, then usually we have diltiazem, but that will also drop your blood pressure profoundly. So we have to be very careful when we give it. So that would be the safety issue for that one. And then measuring that QT, because we're slowing down that time it takes to get from here to here, right? Calcium channel blockers, what do those end in? Pine. Pine. Amlodipine, nifedipine. And then the dysrhythmia, it's pretty much diltiazem and amiodarone. Those are pretty much the two that we use. Amiodarone is generally for ventricular rhythms, so wide QRSs, VTAC, PVCs. But if the patient can't tolerate the diltiazem because of their blood pressure, the amiodarone is going to be a nice alternative. Okay, but when you're learning about them, you want to put diltiazem with the narrow QRS and amiodarone with a wide QRS. Okay, primarily. Is there anything else that I had on that list yesterday that... Statin. Okay, how's the statin going to help?
Total cholesterol.
Okay, lowers your cholesterol. Why is that helpful?
Because it doesn't
Fatty
stick to
deposits.
doesn't stick to the.
So the statin is going to stick to the edges. It's going to gum up the hose, so now the diameter is smaller, and here you are trying to dilate, and the inside is full of crud. Okay? The other part is, if you have cholesterol like floating around and your blood is thick, it just adds to that thick blood. Okay? And then, as an aside, patient has diabetes.
Yeah.
Right? So now it's like a slushy in there.
Just
It's a slushy with fat and it's just gross. Okay? And it's really hard for your poor heart to pump that, no matter what we do for that heart.
So the statin vasoconstricts, you said?
No, the statin just gets rid of the cholesterol.
Both
Oh,
LDL.
the gunk. Okay.
The gunk.
The gunk.
Just LDL, and does it increase HDL?
there's one
It
that
There's one
depends
that
on
does.
which drug.
Okay.
Yeah, it depends on which drug. There is a side effect of statins. There's a side effect of statins, though, that the patient then cannot tolerate the statin.
The liver.
Well, yeah, it does affect the liver, but it's joint pain and stiffness. I had a relative that got started on a statin, and they were in their 70s, and they were an artist, and they were having a lot of trouble. They thought they had arthritis because they're old. It's like a classic geriatric chronic illness thing. And finally, they went to the doctor because it was so bad. And they took them off the statin, and it went away. So that is something that we have to, think about when putting somebody on a statin. And I know it's not us putting them on it, but we're the ones that are going to see the issue or teach about the issue. Okay? So that's kind of the nitty-gritty heart thing. Are there other drugs that are in your
No.
the fibric acids,
Uric acids?
in the middle.
They fall with the
Something acids, and then the bile acids.
These ones.
It's all those Danielle
They
said.
fall under the hyperlipidemia.
Oh, okay. So it's gonna be the same thing as the
These
statins.
ones.
Yeah.
So they do the same thing?
Yeah,
Okay. They get rid of the junk.
yeah.
We
Get rid
also
of the
gotta
junk.
do just key labs and tests.
It's all the way over
Key
there.
labs
Oh,
and
okay,
tests.
okay. All right, so when we're talking about heart failure, all of this stuff is important, right? What labs are we doing? What key labs? Need to know labs. Can I see this one?
Potassium.
Potassium
But
and creatinine for everybody. What's the other thing that helps us diagnose heart failure?
BNP.
BNP. Brain
Neuro.
natriuretic peptide. It's normally 0 to 100. Anything more than that is called CHF. The higher it is, the worse it is. So if you have somebody who has a BNP of 200, they're mildly uncomfortable. You have a patient that's 2,000, they're drowning. They're in pulmonary edema, pink frothy sputum, ICU, the whole thing. Okay? So that's one of the key labs that we use now. We used to have to use an invasive line to assess this. Now there's a lab test. Okay? And they'll only do it once. They're not going to keep drawing it over and over. It's kind of a check-in. Is this heart failure or is this a lung thing? Okay? Diagnostic tests for the heart, key diagnostic tests.
Echocardiogram.
Okay, so an EKG, and what did we want from the echo?
The ejection.
Ejection fraction. What's normal-ish?
Ejection amount. 55%.
Yeah, somewhere around six. I just remember 60, but somewhere around there. Because I already remembered 60 for the apical, so it's kind of all, you know,
Near, it's close to.
I don't know, 50 to 60, probably depending on what you read, is normal. You can't pump everything out of the heart, because then there'd be nothing left in the heart, right? So if you can pump more than half of your blood out, fabulous. That's enough to pump, to perfuse Betty, okay? But we have patients that are 5%.
Whoa.
Their heart's going. And you wonder, how are you getting around, right? They're fatigued, they just don't have any energy to do anything, they're weak, they might be in the, bed bound, whatever, okay? So a lot of our low EF patients have had a very long cardiac history or they've done a lot of drugs. So I mentioned that the left ventricle is doing most of the work, right? So when you have a patient that has left ventricular dysfunction, they're gonna have a low ejection fraction and they're gonna be much sicker than a patient with right heart failure. Because you're talking about the main part of the heart that's doing the majority of the work.
So I had a patient that the one that you gave me, she was diastolic CHF, so that falls into that one, right? The left ventricle?
Yes. And then you have the mnemonic, the pink puffer and the blue bloater,
Okay, let's see.
right? Or is that COPD?
COPD.
That's COPD, excuse me.
The pink puffer.
The right, yeah, I went over to COPD for a minute. Whoa. No, so the right heart failure is more, you're backing up into your lungs, you're gonna have the JVD. Left ventricular heart failure is what everybody thinks of when they think of CHF. You're filled with fluid in your lungs, you can't breathe, you're short of breath, you need Lasix, you're edematous, okay, that stuff. Though the right heart failure is also serious, it's not as, the patient doesn't appear as sick as the one with the left ventricular failure, because their left ventricle is still working.
So for right heart failure, right-sided heart failure, the symptoms would be more like respiratory.
No, the more vascular. They have the JVD.
Okay.
That's like a classic symptom.
The
Okay.
edema, right?
The edema, usually their heart's working pretty hard. Tachycardic.
Oh, ascites?
Ascites. Okay, yeah, so the left ventricular one is where they're like drowning. They're like in fluid overload and
So you said
it
left
crackles.
is an emergency.
Yeah.
Okay.
Yeah. But irregardless of the data, your BNP could be high, you've got a low EF, patient's not taking their meds, their blood pressure's high, the patient could still look okay. It just depends on how they compensate, right? So you always have to look at your patient. You can't just go, oh, Betty's BNP is 2,000. I better give her Lasix right now. Well, you better go listen to Betty's lung sounds first. Look at her oxygenation. Yeah, she probably will need Lasix. But how do you know? You don't know unless you're not treating the lab. The lab is just more data to support what you find when you assess the patient. You always have to remember, look at the patient. Okay, regardless of what, because maybe it was a false lab, you know, maybe it's somebody else's lab. Who knows? You don't know till you go look at Betty. Any other questions about
The goals.
this? So the main goal is to decrease the workload of the heart. Because the heart is suffering, and when the heart suffers, everything else suffers. You don't perfuse well, so you don't get enough blood to your major organs, especially your kidney. And you know, you need it to survive. So when the heart suffers, everything suffers. So we want to make it a little bit easier on the heart. Okay?